Normally I like to wait, but I think we're just going to get started here. Anybody want to take a stab at why I put a piece of Velcro here?
Retinal tubules.
Dental tubules. Yeah, so we use dental tubules very similar to how Velcro attaches itself. So dental bonding is somewhat similar to how Velcro works, which is obvious. I think we all learned this in school, but in reality, when we put glue on teeth, I don't think we're necessarily thinking about what we're doing. We're just kind of following directions. And what I'd like to do today is actually dive into the science a little bit and get a little bit granular in how we think about what we're doing on a daily basis. Beforehand, I want to take a look at this slide. This is not related to bonding. Whenever there's a cool clinical case or something that comes across my radar, I typically throw it in that week's NECADE PowerPoint slides, and this was one of them. In a nutshell, when we pull teeth, knowing where the bone is on the adjacent teeth, the interproximal bone, is an important metric that determines whether or not we're going to get recession post-extraction. This was an implant placed by one of our doctors. Very, very nice implant placement. Nothing was done wrong by the provider. But this was an interesting observation when he had shared with me kind of the post-op iTero scan. What do I mean? The bone that was between the tooth that ultimately was removed and this tooth here. So the bone between 8 and 9 was most likely at a relatively good level, cervical and incisally. Whereas the bone level between 7 and 8 was not. So before we extract teeth, we can look at the periapical films and actually look at the bone between the teeth to assess whether this is likely to happen or not. Here's why this is important. This is going to be a difficult tooth to restore. And if a patient isn't properly educated on the challenges that might ensue after the tooth is removed, they might blame the dentist or the providers associated with that. We have ways of resolving this. I don't want to say it's something we can't resolve, but always better to have as much foresight in our planning as we can. And looking at the interproximal bone of anterior teeth adjacent to teeth that we're about to extract is a very helpful tool for us to tell patients, look, you don't have any bone there. You might have tissue there now, but once we remove the tooth, the tissue will collapse. So, interesting observation. Anybody have any insight here? Thoughts? I promise it'll show up. Now that you've seen it, you'll see it more. Bleeding pulp management. One of the doctors had a endo on an 18-year-old, and she couldn't get the bleeding to stop. So this is from a different presentation I did years ago. In essence, how do we go about? Let me see if somebody came in. Let's leave that. So how do we go about getting rid of a super hyperemic pulp? That's an official diagnosis, by the way, super hyperemic. In a nutshell, you have to get rid of it. So this is the little workflow that I created years ago, mostly from guidance from my endodontic friends and mentors. In a nutshell, get an estimated working length, use full rotary to 75% of that length to get rid of as much of that hyperemic pulpal tissue as possible. And oftentimes the bleeding will stop because you really can't do much if it's bleeding. You can't see, you can't use the apex locator. Very frustrating moment, and this might go on for hours and hours if this isn't done. So if it's still bleeding, take a working length radiograph at 75% to try to get your working length so that you can get rid of as much of that pulpal tissue as possible. All right. Obviously, ibuprofen pre-op does work. I've had this with patients. Ibuprofen pre-op for lots of things that we do can decrease the inflammation associated with problems perioperatively. And then lastly, intrapulpal injections, which doesn't always work with these bleeders. It helps with anesthesia, but not so much causing hemostasis. And then lastly, this was a case that was shared with me over the weekend. 8 and 9 are veneers. And this patient's been having issues with the veneers. I don't know how old they are. Very beautiful case.
They're crowns.
They're crowns, Chad?
They were veneers and now they're crowns.
Now they're crowns. Okay. You recognized the photo. So Chad sent me these photos, and these are beautiful photos, Chad. Very, very well done. I mean, looking back here, I love when doctors send me high quality photos so that we can have a good conversation about what's going on. But this is the problem. So you said they're crowns, but they're kind of 3/4 crowns, or I don't know, 5/8 crowns.
No, so on number 8 there, that whole lingual portion is fractured off.
Ah, so they were crowns and now they're fractured off.
Yeah, so you can see the margin, that little white line kind of all the way down towards the gum line. That's the margin.
Down here?
Yep.
Yeah.
And then on number 9, that line that looks like a margin is actually a fracture line in the same spot starting on that one.
Gotcha. Well, I actually like that even better, because what I was going to share is even more emphasized based on the fact that that was actually restorative material. So the envelope of function, Poiseuille's envelope of function, or envelope of motion, is somewhat of a academic exercise, or at least that's what I was taught, that this is something you need to know just enough to pass your board exams. When you get out in the real world, it doesn't really matter. And that's very untrue in my eyes. And the reason is this zone where the mandible travels. When I say the mandible, I'm talking about the incisal edge of the lower anterior teeth is connected to the mandible. So when I say the mandible, I'm actually talking about the incisal edge of these lower teeth. And how that incisal edge interacts with the upper teeth is everything. This is, in my opinion, what causes a lot of TMD through entrapment. It's what inhibits the CRCO slide, freeway space, and it's what causes problems like we just saw with Chad's patient. So understanding that the mandible wants to be somewhere, and a lot of times the position of the teeth, see how this tooth here is retroclined compared to this properly proclined tooth, the envelope of function is restricted. When the envelope of function is restricted, bad things happen. Loose teeth, fremitus, periodontal compromise, broken restorations, so on and so forth. This is a very deep topic, but I just wanted to plant the seed here that understanding the envelope of function in the everyday restorative general dental practice is absolutely important for predictable outcomes. Chad, do you have any idea how long those crowns have been on? Was it?
If I remember correctly, they were veneers up until like 2017. They had broken. The crowns were done, I think, in 2017. And then one of them had broken in 2018 and redone. And now here we are 5 years later and they're breaking again. So this is kind of attempt number 4. First time I've seen the guy, and just want to get him some long-lasting crowns.
Yeah, there's something out of the world of prosthodontics called a custom incisal guide table, which, again, we're going off on a tangent, but I just wanted to share this concept. Maybe we'll have a whole separate session on it. If there's anything that dental school doesn't prepare us for, it's the topic of restricted envelope of function. They present it to us, but how do you manage it is very difficult, and you really have to go get that information. And I'd be happy to help anybody with a case if they have any challenges, so that you don't end up with this problem. And Chad, I think you had shared this patient is rather frustrated.
Yeah, rightfully so.
Yeah. Fortunately, it's not a patient of our practice. All ceramic crowns on the anterior with no creation of freeway space is not something we would have done. With that said, frustrating for the patient nonetheless. Now, what's important, and here's another patient, these are just natural teeth. We see this from time to time, this very strong groove associated with their virgin teeth. Yes, there's an erosive component here, but the reality is that groove is from lack of envelope of function. So their muscles want the mandible to be where the upper teeth are. Here's another nice diagram. The reason I put this here, when we adjust occlusions, we often have the patients tap, tap, tap. We talked about this in the occlusion lecture a couple weeks ago. Tap, tap, tap is only the beginning of the process of adjusting a restoration in the patient's mouth. You have to put the patient through function. And if and when we do that, we find a lot of information about that freeway space or that envelope of motion whatever term you want to use. It's the dynamic process of that lower incisal edge traveling along the inner surface of the upper teeth. The point is, oftentimes the muscles don't like that interaction and bad things happen. Here I put the envelope, these are the border movements. Here you have CR, here is CO. This is the protrusive guidance. Then you have your incisal edge. This is when you fall off the other end, and then your maximum protrusion. This is your border as you open for maximum protrusion, but there's a chewing stroke in here. The point is that somewhere in here, if you restore in the wrong spot, you're going to have problems. You don't want to restore in this zone. This zone is a dynamic movement of the mandible. Another explanation here and how it relates to the hinge axis. So important concept I just wanted to share. Another one that came up, several of us use Glidewell. I'm proud to say it because I have figured out how to play the game that Glidewell plays. And a few of you guys on this call have used Glidewell and had success, and others have had horrible outcomes. Is it the lab, or is it something we're doing? And I've come to the conclusion, or at least what my working theory is, on high volume labs. So we use Glidewell when we just want to have a Bruxer zirconia on an insurance-based patient. They do a really good job, but you have to prep the tooth right. And what I found is when I've been looking at doctors' cases when they share with me that Glidewell sucks and the crown didn't fit, most of the time this is their prep design. It's a very circular prep design that has very little resistance and retention form. Yes, the taper here is good, but in reality, when we mill a crown, the fit on this is not going to be great because there's really no indexing here. I've been putting grooves in my preps for the most part, especially shorter preps, for several years now. And what I find is when I put grooves in, my crowns fit way better from Glidewell. Now, why am I picking on Glidewell? Because we all know Glidewell mills their crowns. If you do a PFM, I'm pretty sure they still press the metal ingot that's underneath. But for the majority of the profession that's now using zirconia because of its superior aesthetics and structural integrity, so on and so forth, you're getting a milled crown. Well, the intaglio is not very intimate with the crown prep unless you put retentive grooves. So when you put retentive grooves in, you're increasing the information at which the crown is going to index itself onto the crown. So what I would encourage everybody to do, if you're using a lab that you know is milling, it doesn't matter if it's Glidewell, NDX, so on and so forth, if you find you're having ill-fitting crowns, that they just don't, they kind of hang over on the mesial and they're short on the distal, start putting little retentive grooves. And there's different ways of doing retentive grooves. You have to have a path to draw, so on and so forth. Add this to your everyday crown preps and see what happens. I have not had an ill-fitting crown from Glidewell. I don't know. It's been quite a while, and I attribute it to not having preps like this. Anybody want to comment here while I take a sip of water?
I had spoken to someone at Glidewell, and they had told me that, because I had always put retention grooves in my crowns, and they told me that for the most part, if they're scanning and milling and designing digitally, that a lot of the grooves are just going to erase out. They're going to design over it anyway. So they encouraged me to not put the grooves in there. But I understand exactly what you're saying. The retention grooves should help index it in place better.
Right.
So when you look at the inside of your crowns, you can see the positive portion that fits into the groove.
Yep, this guy right here. Yeah, I'm not sure. Maybe I'm making them a little bit bigger so that they're being picked up better by the scanner. It's a concept that I think communicating with the lab to try to get a better sense of what they're looking for, what they need to do so.
Maybe my retention grooves were too narrow, because they were saying that the milling burrs they use have a width of 1.4 millimeters or whatever. So they said they can't, if it's narrower than that, they can't really mill into it. So they're going to, the computer will say, oh, I can't mill that intimate, and it'll just erase it out.
Right. Yeah, I would say mine are a little bit bigger than this picture here, but I make sure they're V-shaped. I don't know if that makes a difference or not. If I have like a 2 millimeter axial height on number 18, then I definitely go to something smaller like this, but then I also don't use Glidewell. I use a different lab to make sure it's pressed to get that intimate fit. But in general, when I'm just doing run-of-the-mill dentistry and I just want a $99 crown that looks good and is going to last really forever, I create something akin to this. So,
well, that's encouraging. Maybe I should go back and do more of that then.
Yeah, and I'll revisit my records. I didn't know, this is a recent observation of mine, but I do know I always look for that positive indexing because it feels better when you seat it. It feels more like a cast crown used to feel when you put them on. It wasn't that sloppy feeling like we get with the milled crowns now. But food for thought. These are small things that move the needle in the right direction for us for more predictable dentistry. Nothing's more frustrating than putting a crown on somebody and not having it fit. For saving $99, saving $100 to get a $99 crown, if it doesn't fit that first time, you've already lost your money. So getting this stuff to be very predictable is key. All right, what are tonight's objectives? Let's see how much time we have. Yeah, I'm already 20 minutes in. So I'm going to skip over what are we doing tonight. A lot of you guys saw this in the email. In a nutshell, we're going to go through the modern literature in order to construct the best and longest lasting bonding protocol that is also very efficient and predictable in anyone's hands. We have over 10, 11, 12 doctors in our organization. I want to come up with something that makes sense, that works well for everybody, but is very predictable. And that's really the impetus of tonight's talk. What we're not going to talk about tonight, the various generations of bonding agents, although I love talking about that, not really the topic for tonight. I don't really want to get in the topic of OptiBond, FLO, and Clearfield SE as the gold standard bonding agents. I love both of these. I just think that they're more technique sensitive than what I'm proposing to put together tonight. Light curing topic in and of itself. Enamel bonding, I think we all know enamel bonding is relatively easy and there are ways of improving it, but that's not what we're going to cover tonight. We got one more member coming on. All right, so what's the issue? I gave my first talk ever in front of my peers was at the Greater Portland Dental Society back in 2015. And before I did that, I sent out an email to colleagues of mine, friends that were dentists, and I asked them the following question. Do you know the name of your dental adhesive? 73% said yes, which means 27% didn't know the name of their dental adhesive. Do you know what generation your bonding belongs to? 43%. Is that relevant? I don't know, but I think it's painting the picture that I think we have some room to grow as far as understanding what I would consider the most important part of our restorative practice. Do you know with certainty the exact directions of your dental adhesive? 52%. Do you know do you use your bond because somebody told you to? 4/5 of the people said yes. Do you consider your knowledge about dental adhesives to be sufficient? 23%. Ed Swift, who has taught at MasterTrack over the past 10 years, and I've talked to him quite a bit, I've been out to dinner with him, gave me this reference once that he had made a comment in the pediatric journals, Pediatric Dentistry. Unfortunately, many clinicians fail to follow directions provided by the manufacturer and either intentionally or unintentionally misuse bonding systems. Yes, he said this in 1998, but keep in mind, in 1998, the dentists were more, Steve, maybe you can speak to this. I think back in the 90s, bonding was still suspect. Amalgam was still used quite often, so people were a lot more diligent in following directions. So if he said this back then, you can imagine how lax providers have become now, where we kind of just think we put this stuff in people's mouths and cure it and they're good. And that's really what I want to try to dissuade from tonight. Fast forward to 2012, Jerry Kugel, he teaches down in Boston, does a lot of research and publishing, and he echoed this comment that most providers have no freaking clue what they're doing. I'm sharing what other experts and mentors of mine have shared. And I went out and got objective data, but I can tell you, that even myself at times forget exactly how long I'm supposed to be scrubbing the bond into the hybrid layer. So let's continue. Point is, I believe there's value here. We all know not all substrates are created equal. How I'd restore this tooth because of the 360-degree rim of enamel is very different than this guy here. Here's a really nice diagram of the concepts we're going to discuss tonight. Another article that came out that says basically the routine and established use of bonding techniques for more than a decade led to a degree of laxness in technique. Less than precise technique can result in an increased potential for post-operative sensitivity and future debonding. So my emphasis about really focusing on this protocol is not just my soapbox opinion. This is really a collective thought within the profession itself. So what is the mode of sticking to dentin? We're not talking about enamel. We're talking about dentin here. They're two different animals. We all know that sticking to enamel is a very predictable and relatively straightforward process. How does it stick? Is it a chemical bond? Is it a mechanical bond? Micromechanical bond? A chemical and mechanical bond? Or a chemical and micromechanical bond? Anybody want to take a stab at what the answer to this is? So that's the overarching answer. Again, it's Velcro. There's very little, if any, up till recently, very little, if any, chemical interaction between the resin and the tooth structure. It's basically just this infiltration of a very wiry resin matrix into a very wiry collagen matrix inside of the tooth. And when you cure it, you lock it in place and you have, in essence, what Velcro is. But fast forward to recently, and now there's some talk about we have a chemical. That chemical is MDP that may or may not actually have an ionic bond between resin and the tooth structure itself. We're going to take a look at that. Notice the several question marks here. Again, there's our friend the Velcro. I said earlier that we weren't going to go over the bonding generations, but I think it's important to quickly just throw the slide up here. Fourth generation OptiBond FL, still considered the gold standard in the literature as far as superior bond strengths and long-term maintenance and integrity of the bond. Fifth generation Prime and Bond here, sixth generation Clearfill SE, which again is a gold standard. There's a lot of really good products in these three generations. The seventh generation, stay away from. So if it's a product that's primarily etching itself, so it's everything in one bottle, the literature is very clear. This is a very poor material to use. G-Bond, Prompt, L-Pop, and several others live in this category. These were very popular around, 2011, 2014. We don't hear about them anymore. So I always advocate, let somebody else try out the new products and let them screw up, because there would be nothing worse than having several hundred patients come back and you have to redo their restorations because you used a new product that was not able to stand the test of time. So here we have our odontoblasts within the dentin matrix. The reason this is important is there's nerve endings essentially within this dentinal tubule that senses changes and inadequate bonding. So we'll come back to that. But here I have a very basic diagram. I'm gonna build upon this particular image here. This is my attempt at just saying this is what dentin looks like from a very simplistic nature. All of these little squiggly lines are collagen. Collagen is the organic matrix that makes up the dentin surface. I didn't put the tubules in here yet, but I will. In between is an inorganic matrix of minerals. So there's a mineralized complex, and it's the combination of those two that give dentin its character. Superimpose upon that more of a macro structure. We have these dentinal tubules. And here's a simplistic diagram to show that. This is with the composite resin from the composite. Here's our adhesive. the hybrid layer, the collagen, and the mineralized dentin, and then the resin tag that lives within the dentinal tubule. This is one of the best diagrams, and I'll happily share this PowerPoint with anybody if you guys want. This is the best simplified diagram I've ever seen that exemplifies with a high degree of accuracy what's going on during the process. I'm going to hopefully articulate this with my slides, but I found this recently and I wanted to bring it here. I'll bring it back up shortly. But let's start here. What happens when we are removing decay? We create the smear layer. So the smear layer is not something that organically lives on the surface of dentin. We create it through the use of high-speed handpieces, slow-speed handpieces. Essentially, it's just the mud that's created from the debris during the cavity preparation process. Well, here we have the dentinal tubules. We have the peritubular dentin, intertubular dentin. Here's the etching process where we demineralize part of that, the mineral content of the superficial layer of dentin, primer and adhesive. This is a little bit more of the 4th generation process, but suffice it to say, when we're done, this is essentially what the hybrid layer looks like. It's an interaction of hydrophobic composite, hydrophobic slash hydrophilic adhesive resin, a resin tag, and then the hydrophilic hybrid layer. And here we have a SEM representation of that. So here I'm building out my little diagram. I did this several years ago, and it took me a lot of time, so I wanted to resurface it today, and I've actually built upon it because I'm trying to use PowerPoint to try to paint a story. A picture tells us only so much, but if we can actually use PowerPoint to actually deliver a message, I think that will translate well to us clinically. But it's important to know that there's 2 bonding interfaces. This is very important. When we're thinking about the interactive surface that we're trying to glue to, we have the surface of, here this gray layer is the smear layer, but underneath we have that mineralized matrix and collagen that we're trying to glue to. But we also have the dentinal tubules, which we're going to try to access this 3-dimensional keyhole to try to gain further retention. I want to look at these separately because how we treat them and how we think of them is going to be very different. All right, so transition slide. Wherever we see a yellow slide and where it says transition slide, I want us to kind of go from one concept to another. This is the process of bonding. Nobody's surprised by the steps involved here. But we're going to go through each of these and we're going to look at the literature on how we should do these exactly. I'm going to talk a little bit about Scotch Bond Universal. That's the product that we use in our office the most. I don't necessarily think it's the best product in the world. I think it's the best product for the masses because it's the least technique sensitive, best studied MDP containing adhesive out there. So there's a reason why I've chosen it for our practice. With that said, I know there's better options out there for the more savvy clinicians. So again, I'm going to be somewhat product agnostic as I go through this. All right, so let's start with the etch process. Let's start with a question. What is dentin etching? This is another question to see if anybody wants to put their neck out on the line and try to see if they can get it right. Is dentin etching removal of organic debris in the hybrid layer? Is it reorganizing of the mineral and organic strata? Is it removal of the smear layer? Is it creation of organic tags for bonding? Is it demineralization of inorganic apatite or hydroxyapatite? Or is it deactivation of MMPs? Anybody want to take a stab at which of these is correct?
It does remove smear layer, doesn't it?
That is correct. All right. So it's a little bit of a trick question. That is one of the answers. There's one more which is less obvious and less well known, but I think super relevant in the world of universal adhesives. But that is correct. Demineralization of the inorganic apatite. So we talked about this hybrid, not the hybrid layer because it's not hybrid layer yet because we haven't necessarily added composite or adhesive to it. But the dentin substrate has a mineralized component, and etching removes that mineralized component. When I think of etching, I don't know why I think of this. I think of marble, and if you put a chemical on marble, it wouldn't be as smooth. I don't know. That's just how I remembered it. If it has any relevance to you, great. But I think it's important for us to know that what we're doing is we're creating a demineralization front. Super important. Let's get rid of the minerals so that we can replace it with resin. This is that diagram. I cropped out the unrelated topics here. But in essence, when we're etching, we're removing the smear layer. You can see the smear layer is gone. It is important to know that some bonding generations incorporate the smear layer. Not the topic for today, but there is some validity to that concept. I do not subscribe to that. But it is, there is some value there to understanding when we keep the smear layer, what are we trying to do? But here, with acid etching with phosphoric acid, we remove the smear layer, but we also create a demineralization front. This is very, very granular in understanding what we're doing when we're etching and bonding. I think this is important because I'm going to supply some steps here that are contrary to what we're taught in school. If we don't understand this process, the steps that I'm going to suggest are going to sound stupid and superfluous. I know that because I've had people tell me that. Then I asked them to describe to me the process that they use, and it's, well, no, I was just told to use product X from school. It's like, okay, that's great. And that's nothing against the providers in school, but there is no more important process in restorative dentistry than this. So I think it behooves us to really understand it at a deep level. So here we're back to the slide here. We have bonding interface 1. This is when we are etching the intertubular dentin. Then here we have the etching process associated with the dentinal tubules. So let's look at bonding interface number 1. So here we have not the hybrid layer, the dentin substrate, collagen fibers, and the mineralized complex, and we have the smear layer on top. So here we bring our etch on, and we remove the smear layer, and we create this demineralization front. So you can see how the surface here is more white than this here. This is what we're aiming to do. Our bonding agents don't necessarily want mineral associated with it. Plus, we have to remove the mineral to create space for the resin to get in here. So if we don't demineralize, we don't create space. It'd be like having flat Velcro, or where the Velcro loops are kind of laying flat. That would not be a bonding surface we'd want to adhere to. So creating this demineralization front is important. So how do we do that? There's a concept, there's 2 articles in the literature that I found, and I've been through the literature on this topic of bonding probably 5 or 6 or 7 times over the past 10 years. And I have yet to find another article that emphasizes why brushing our etch is important. But here's my line of reasoning. 1, it was studied and it was proven that it has a positive outcome. There's the article here. Happy to share the actual article with you if you'd like. But I think of a dog bowl where you have the schmutz here. That schmutz is akin to the smear layer. Now in a dog bowl, that's a biologic substrate that is somewhat adherent to the bowl. And you could imagine if you just put bleach in there and let it sit for 10 seconds and then you rinsed it out, you're probably not going to get as clean as if you put bleach in there and then you took a scrub brush and you scrubbed it. So I've been doing this for 5 or 6 years. I can't say this is the reason why we've had good success, but I haven't had a filling fall out, knock on wood. I haven't had a high degree of post-op sensitivity. I think this is definitely part of the process, and the literature supports this. So when you add etch, remember how viscous etch is. It's really viscous. They actually put additives in there to give it substance. And if you don't go in there and break it and give it some energy, the actual etch itself, the phosphoric acid, is not going to interact with your smear layer and your dentinal tubules as much. We want to get down deep. We're not going to do that just by placing it in and then rinsing it out. So here's a copy of the details to that article. What they did is they took the etching technique, they have tips, and they didn't describe what the tips meant, but there are specialized tips that expel out phosphoric acid that are very kind of thin. They create like a shear force to break up the viscosity of the tip. So that's what they were measuring here. Let's ignore the with tips section just for the argument. But they actually measured passive and active. Active was actually agitating the etch. And you can see here the dentin bond strengths went from 19 to 32. They didn't change anything else. All they did is agitated the etch. Food for thought. So here at the end, they say the acid etching time, because they did measure time as part of this study, but I didn't highlight that here, and technique. So they're talking about the agitation of the etch itself, significantly influenced the bond strength of the etch and rinse adhesive to dentin. Activate the etch. So all I do is I take a micro brush and I just scrub the entire surface. Makes me feel better, if anything. Plus it gives me something to do. Here they went over acid etching time. This has been corroborated in many other articles where 15 seconds for dentin is the optimal time. If you over etch, you have a decrease in bond strengths. Whereas enamel, there actually is very little difference between 15 and 30 seconds. This was the second article that talked about agitation of phosphoric acid etch. Here they actually use staining to show what happens. This bonding interface, this hybrid layer, is with agitation of the etch. This is without. Again, all other steps were maintained. They actually looked at the etching times between no agitation and agitation. And here you can see there's, with all of the times, there actually was an increase in depth of penetration. This doesn't mean that longer times are better. It just means that the more that you scrub with more time, you have a deeper penetration. There is a law of diminishing return. Point is, this is 6.5 at 15 seconds is better than 4.0 micrometers. Here was their summary statement. Etching technique could have a large effect on the degree and uniformity of both dentin demineralization and the interfacial structure. Here's another SEM. This is our smear layer. Here's our exposed collagen network where we remove the smear layer from the tubules. And then this is what it looks like when we properly remove the mineral content. We create a microstructure, almost like a receiving end of Velcro. This slide was from that previous lecture. I just wanted to put sclerotic dentin, multiply your etch times by 2. Whether or not you're doing a self-etch technique or total etch. This has been proven in the literature by 2 very leading scientists in the world of dental bonding, Tay and Pashley. You'll see their name come up a lot. All right, so that's bonding interface number 1. Bonding interface number 2. Here we have the etch. How do we get that stuff down in the dental tubules? Do you think we're going to get it down simply by just putting the etch onto the smear layer? Well, if we activate it and we scrub it, we're going to push it down. For those of us that do endo, I'm a huge fan of the endo activator. What is the endo activator doing? It's adding energy to the very viscous bleach within the canal system. When we take a microbrush here and we add energy to the etch, we're more likely to get movement and further demineralization deeper into the dental tubules, removing the smear layer and any sort of mineral component that exists. With our goal, creating this nice, open, three-dimensional structure for us to bond into, creating a nice three-dimensional macromechanical retention. All right, transition slide. Anybody have any comments about etching?
The agitation of etch is not particularly new, though, is that? Haven't they been
It's not new, but it's not commonly taught.
done? Yeah.
Yeah.
And there are some etches that are thicker than others. I mean, the only reason we color our etch and we use the etch in a gel form is so we keep it from running and to see it.
Sure.
But the thicker the gel, and sometimes if your gels dehydrate quite a bit, if you have an old etch that you shouldn't be using,
Right.
you can tell immediately, oh, that's not going to be good.
Sure. Yeah, and I've definitely seen that, depending on how well the cap is put back on or how old
Sure.
it is, how close it is to expiration. But yeah, the concept of agitating etch, definitely not new, but it hasn't been studied that much. And I think because of that, it hasn't necessarily been translated. And, I see the doctors practicing, and I have assistants tell me what certain doctors do and don't do. Very few doctors scrub. And these are doctors that are taught from a variety of institutions in the Northeast. So I consider this a very important topic to cover, and the literature supports it. So what about rinsing? Rinsing is important. Just like Dr. Palmer said, sometimes there's it's more viscous based upon how much it dries out. But they add thickening agents to it. If they had just phosphoric acid, it would be extremely runny, if not impossible to use. So there's all kinds of other things in there. The reason why it's important to know there's other things in there, these things interact and inhibit polymerization of our resin. So we've got to get this stuff out. So here I put a little clock. Most companies have a recommendation to rinse for anywhere from 10 to 15 to 20 seconds, rinsing the etch off. In the sake of time, I'm not going to do the exercise that we thought, but I think everybody will understand where I was going with this. I was going to have us all pretend to rinse for 15 seconds. That's an eternity. 15 seconds to 20 seconds of rubbing the adhesive layer in is an eternity. There is a very big difference between what the companies do in vitro versus what we do in vivo. Big difference. But those times are there for a reason. They've tested it. So I would encourage everybody to start actually counting 1 Mississippi, 2 Mississippi. You're going to go crazy. I promise, because I've done it myself. The point is that when directions say 15 seconds, they really mean it. And there's reasons for that. The performance of the bonding agents that you use is directly dependent upon the time that is recommended by the manufacturer. I promise you, very few, if any of us, are doing 15 seconds of rinsing. So when spraying, vary the pressure in the water spray. That's another kind of important point. Sometimes what I'll do is I rinse, and then I air dry, and then I rinse again. I'm using varying pressures, varying angles. I'm looking to make sure I have all of the etch out. It's an active process. Removing etch is an active process. It's not passive. All right, so step 2, rinse thoroughly for 15 seconds with varying the spray. The topic of re-wetting agents, in a nutshell, we can over dry. When we over dry the collagen, we flatten it. This is a very difficult surface to bond to. It's been shown many times over the years. There are certain techniques that actually prefer a dry surface, but those have given way to the more wet bonding protocols that we're used to seeing. It's nice to have a properly hydrated collagen matrix. Here I put an article by Pascal Monnier. Most of us have heard of him. He's a leader in the world of dental material sciences. And he talked about using suction as a way to remove the moisture from dentin. Just want to plant that idea here. So how do we optimally dry? Well, first of all, read the directions to know, should it be dry? Should it be wet? Should it be moderately wet? What exactly should the surface look like before you apply your adhesive resin? Read the directions. I promise you're going to be surprised what's in there. The ADEC air dryer, this is something I dabbled with years ago. I don't think we need this. I'm not going to dive into this too much more, but this was a very popular product 10, 15, 20 years ago. Using a cotton pellet can remove some moisture. That's a way to control how much moisture is in there. And then lastly, using a wetting agent. If we over dry it, how do we add the moisture back in? Here's a nice diagram of what happens when we over dry. We're not talking about the tubules here. We're talking about the collagen matrix in the intertubular dentin. This is a properly rehydrated matrix. This is what we want, this coral look. Our resin needs to go in here. And our resin goes in there through the use of a solvent, chasing out the water. We all know that process. The point is that if it's overly dried, we're not going to get good bonding. So here we have our etch process, and here we have re-wetting. But what about re-wetting with something else? So we all know gluma, we all know chlorhexidine, we can use water. I'm going to advocate for chlorhexidine, and we're going to go into this a little bit right now. What is chlorhexidine's use in the bonding process, specifically re-wetting? Well, we all know adhesive bonds of dentin degrade over time, no different than this bridge fell apart here. It's kind of the it's the part of resin bonding in dentistry that we're trying to supersede. We're trying to create a bond that actually doesn't degrade. When that happens, it's going to be a rather monumental moment in dentistry. But here we sit. One reason why I talk about the 360 degree rim of enamel, our degradation is very different if we have a moat of enamel bonding around it. So this topic is true under certain circumstances. But essentially, we have hydrolytic breakdown of the hybrid layer. Chlorhexidine, through deactivation of MMPs, we've all heard that term, matrix metalloproteinases, are enzymes that live in the serum within our hybrid layer that degrade collagen, degrade exposed collagen, and eventual breakdown of the hybrid layer. So chlorhexidine has been shown to deactivate MMPs, but what chlorhexidine hasn't been shown is to actually improve bond strengths over time. So as much as I love chlorhexidine, I don't think it's actually that relevant. I still use it every day. I think back to this meta-analysis on the effect of chlorhexidine on bond strengths. There's quite a bit of study that's been done over it, and here was the summary. I'm going to read this yellow down here. Chlorhexidine pre-treatment may not be as important as we once thought, but stay tuned. What they found is there's a strong deactivation of MMPs up to about 6 to 12 months. They start to fall at 16 to 24 months. So a couple of years later, the chlorhexidine is mostly gone at that point. And the studies didn't really show a connection between deactivation of the MMPs and bond integrity over time. There's something that we're missing here. So I don't think chlorhexidine is necessarily super important. I use it because I want to have a re-wetting agent. I want it to be something that has antibacterial properties. I do think that there's probably some effect on decreasing post-operative sensitivity. Can't say that for sure, but it's an idea that I have. But in reality, there is some effect here, and we might as well use it. With that said, proper wetting or re-wetting of your surface with water is far more important than any sort of chemical that you can put in there, and that the literature is pretty clear on that.
Do you think this is like the biggest reason for post-op sensitivity? Like everything I've read is that over drying before you bond, or then over drying your bond or something, is the actual physical drying of it is one of the main reasons of post-op sensitivity.
100%. I do not believe you can over dry the resin. We're actually going to talk about that. As a matter of fact, I'm going to advocate that you super dry the resin. But you're right, when you overly dry the dentin surface, you're basically not even getting a Velcro effect. And that absolutely is going to cause post-operative sensitivity. Not to mention, if you over dry the fluid that's in here, you're going to leave the odontoblast without moisture, and then you go to apply your resin. That resin's not going to go anywhere. It's going to sit over the hole. That's post-operative sensitivity. 1,000%. Over drying the dentin surface is, at least in my opinion, the biggest reason. We're going to talk a little bit more about drying the resin. Drying those two different entities are two very different conversations. One you have to get perfect, the other you actually want to overdo. That make sense, Ryan?
Yeah, definitely.
Yeah, cool.
Can I ask a quick question?
Yeah, go ahead, Elena.
So the chlorhexidine that you use to re-wet, just to clarify, you're not rinsing that off. You're just using it, and are you like air thinning it, or how?
Yep. So I air thin it, but I also I have the assistant suction. So that's what this article says here, is using air through the air water syringe and suction to dry, whether it's chlorhexidine or water. Essentially what I try to do is, once I'm thoroughly clean, I actually intentionally over dry it because I want to get rid of water. I want to replace it with chlorhexidine. But then I want to dry it to optimal wetness, if that makes sense. So
that was my question. So you slightly over dry initially to get rid of some of the water, and then you re-wet it with your agent of choice.
correct,
In this case, you want chlorhexidine in this example.
correct.
And then you don't want to over dry it a second time. You just want it moist.
Moist. Yep. Yeah, and there's great pictures, and I should have put it in here, of like a sheen surface. You know, it has a reflective surface. You want a little bit of moisture on the top of that, because the water is what's keeping the collagen fibrils up. So if we go back to this guy here, I had another slide where these were flattened down. Moisture, whether it's 2% chlorhexidine, or it's gluma, or it's hema, or water, you have to have something to keep the collagen up. If they collapse and then you add the resin to it, the resin is not going to infiltrate that layer. So you really have to have an optimal surface, not only for the dental tubules so that the solvent can chase the water out, but also for the collagen fibrils here.
I have a question.
Yeah, go ahead, Chad.
Typically, you've been using chlorhexidine and like a gluma or hemaglue.
Yep.
Is that, obviously they have different purposes, but in the context of a wetting agent, you're basically wetting it twice, correct?
Yep. Yeah, so I used to do that, and here's why I don't anymore. I don't think gluma is bad. It's really hard for me to say something against what God Christensen said. That's God Christensen is Gordon Christensen. You know, when he says something, the entire industry goes, "Ooh, that must be true." There's been many things that guy has said has been blatantly wrong. He's done a lot of good for the profession, but he was an advocate for gluma. Maybe he still is, I don't know. But I saw him speak once, and he was talking about gluma, it being the way to decrease post-op sensitivity. It does decrease post-op sensitivity, but what it does not do well is provide a long-term integrity to the bond. So that's what I'm going to go over here. In a nutshell, what is gluma? It's glutaraldehyde and hema. Hema is hydroxyethyl methacrylate. Hema is the most hydrophilic resin. It has the shortest backbone of the biphasic hydrophilic hydrophobic monomer that we make. So if you didn't follow me there, just know hema is essentially what goes into the hybrid layer, because it's very hydrophilic, but it has a methacrylate end that bonds to the hydrophobic methacrylates of our composites. The problem with hema is it's super hydrophilic, and because it's hydrophilic over time, you end up getting breakdown of the hybrid layer. We'll look at that in a second. But what does gluma do? The glutaraldehyde has been shown to cause a precipitate within the dentinal tubules, which the odontoblasts, which live down here, which have the nerve endings attached to them. If you occlude these, you have a drastically decreased post-op sensitivity. If your objective is post-op sensitivity, go ahead and use glutaraldehyde. We can get the same effect by properly etching and properly going through the process we're going to talk about here, where we really do a good job of driving the solvent and the resin down here and not rely on hema and glutaraldehyde. So again, gluma is great if your objective is post-op sensitivity. But if your objective is to have that filling sit around for 30 years, glutaraldehyde is not very good, and here's why. It's called the hema trade-off. So hema-based resins, which the resins that we use have hema in it. There's reasons that you have to have hema to a certain degree. But what they do is they increase bond performance because the hema goes very deep into the collagen matrix because it's a very hydrophilic monomer that has methacrylate on it because of its high water absorption. The problem is degradation over time. So yeah, okay, the red is the bad here, high water absorption. So by having high water absorption over time, you have that degradation that we talked about. At the end of the day, if we could create something that penetrates as well as HEMA, but then was hydrophobic, we would have the perfect monomer for dentistry, but we don't have that. So non-HEMA base, we have poor bond performance, but high water resistance. So there's a trade-off here. This is why I don't like Gluma.
So if you have, I feel like there's like that 2% of the patient population that just has incredibly sensitive teeth. No matter what you do, you'd probably use some Gluma, but for everyone else, consider not.
That's a great question. I'll be honest, I don't think I can answer that. I love your rationale, and I could definitely see myself doing that from time to time. But I'm strongly convicted in the process we're going to talk about here, kind of following this. But I knew somebody was going to bring up the topic of Gluma, so I imported the slides from that presentation. To be honest, if they have high sensitivity, I'd want to address it another way. And there's a couple different ways we can do that. Because the HEMA almost guarantees an increased risk of bond degradation over time, I don't know if it's worth it. It's a tough one. I also don't know if it would necessarily translate to better decrease in sensitivity. So good question. I don't have the answer to. My thought would be no. I think a very solid bonding process is what decreases the sensitivity, not the use of Gluma. So here we talked about that bonding interface. We talked about re-wetting. Now let's actually add the bonding. You can see here I have 2 bonding applications. This is kind of the meat and the potatoes of the talk. I've been to countless lectures on, do we do 1 layer? Do we do 2 layers? There's an article out there that says 5 layers is better. Do we air dry between the 2? Do we cure between the 2? I strongly believe this is the answer. Sorry for the soapbox, but I promise you the literature I'm going to associate with this process is extremely sound. All right. Notice here, there's no light cure between the 2 bonding applications. Notice there is 2 applications, not 1. And notice there's air drying between the 2. And very strong air drying. We're going to talk about that. So get ready to break out the tomatoes. I will gladly receive any sort of contradictory perspective. But in a nutshell, the bond application step. Is scrubbing time important? What does time mean? Well, time means more adhesive delivered. Is that a good thing? Well, it depends on your bonding agent. The universal adhesives, which is part of our conversation tonight, is thinner, which means more adhesive might be better. OptiBond FL, which had a very thick adhesive, maybe more adhesive wasn't better. So again, time isn't necessarily what we're looking for. We have to think about what we're doing and what agents that we're using. More time for the solvent and water evaporation. So time is important. And then lastly, more evaporation between adhesive applications increases the density deeper in the hybrid layer. This is why I do two steps, 2 applications interjected with drying. This will make more sense in a moment. But there's literature out there that actually looks at this. So in the Journal of Mechanical Behavior of Biomedical Materials, what seems like a very robust list of very smart people studied the effect of double layer application on bond quality of adhesive systems. Very, very good article, if you'd like to read it. The point is, longer scrubbing times are better. Double applications is better. So why is it? So let's go back to our little fictitious diagram here. So here we have our intertubular dentin, we have our dental tubules, and the yellow is our resin. The blue is the water that's associated with it. Again, we wanted a nice sheen surface of moisture on the top here. And here we come and we apply our bonding resin, which is the yellow. So if we just add a little bit and we scrub and then we air dry, maybe that's all we get. We just get a little bit of infiltration into the dental tubules. If we had proper moisture, the odontoblast that sits here isn't going to notice the difference between the water that's here and the resin that's here. To Ryan's point, what is the limiting factor or the factor that contributes to post-op sensitivity is when we don't have moisture in here, when we over dry and the odontoblast that sits down here has no moisture above it. That's when sensitivity happens. That air that's in here is very sensitive to temperature change, very sensitive to airflow. The odontoblast is used to having fluid in here, so we need to make sure it stays there. But we can also have that be resin. The point is we want something in there so the odontoblast doesn't feel like it's exposed. So if we scrub longer, here we have this effect. All right, so we're penetrating deeper and deeper. We're creating a really nice hydrophobic layer, but we're also penetrating the dental tubules very deep. This is a superior bond layer, okay? So going back here. That's 5 seconds of scrubbing, 10 seconds, 15 seconds. I'm oversimplifying it to make the point. The longer we scrub, the deeper we go. In bonding interface 2, we go down here. In bonding interface number 1, we go deeper into this layer here. I didn't do a good job of pictorializing that, but I think we get the point that the more we scrub, the deeper we go, the better the bond, the better the interaction. More studies. Actually, this is the same study here. But here, the conclusion, the double application mode is effective for enhancing shear bond strength and shear fracture strength of universal adhesives, but not conventional two-step. So they actually found that 2 layers does not apply to other generations of bonding agents. This is why the literature is so important. Like, you're not going to have take-home messages that apply to every adhesive that's out there. You really got to stick to one adhesive and understand how it functions and how it operates. Best thing you can do is just read the directions from the manufacturer and follow their directions. The biggest mistake I've seen is people will take the directions of the material they were taught in dental school. They'll become an associate to a practice, and then they'll use the same technique with a different material. Very, 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 very common mistake that might have no issue, but might have very significant consequences to the bond integrity over time and also increase the chance of post-op sensitivity. So here, this is more of that article. I took out all kinds of different things because there was a lot in here that I really liked. Not going to go over that. Another article here. In most cases, it is necessary to apply 2 layers of the Dentin bonding agent to the acid etched surface. Somewhere in here, he talked about never curing between the 2. There's a reason for that. Right here. So under no circumstances should the bonded surface be light cured between applications of the Dentin bonding agent. This is a technique that's taught. I've seen lecturers talk about this. I'm not going to dive into it. If you're super curious, I'll tell you why. The point is you do not want to cure between, because once you do, you lock that first one in and you decrease the effect of applying the second. So bonding application number 1, this is the take-home message. Scrub and agitate for 20 seconds. On to air drying. Yes, this has been studied. The effect of adhesive air drying time on bond strengths to dentin, a systematic review and meta-analysis. It's just kind of funny what's studied, but the point is this information exists out there. This was studied back in 2019. I don't know the relative strength of this particular journal article or journal itself, but what they found was the air drying time of adhesives is crucial to the adhesive strength to coronal dentin. Adhesive air drying for shorter durations, 5 to 10 seconds, may be inefficient to obtain adequately durable bonding to dentin. Instead, air drying should be performed for longer durations, 15 to 30 seconds, considering the pressure and the distance of air drying source. That's a long time. The point here is, and Ryan, thank you for asking the question, can you over dry the resin? No. Once that resin is dry, it's not going anywhere at that point. It's locked in. What are we doing? We're removing the carrier, the solvent for the resin. And the more we air dry, the more solvent we dry away. The solvent is hydrophilic. We don't want hydrophilicity in our hybrid layer after it's cured. So have fun. Cure, cure, cure. I love having the assistant hold the high volume evacuation suction while I'm air drying my adhesive layer. Again, I do this twice. This was another article here. It might be concluded that air blowing time had no influence on the bond strength of acetone-based adhesives. So I put this in here because there are some bonding agents. I think Voco may have an acetone-based adhesive. Ethanol is much more difficult. Let me rephrase this. Acetone has a very low vapor pressure. It evaporates very fast. Why is it that when females remove their nail polish, you can smell acetone on the other side of the house? It's very volatile. So you don't really need to air dry that stuff as well. One reason why I don't like it is its vapor pressure so low that you have to work super fast to drive it into the hybrid layer. So most common adhesives use ethanol, Scotch Bond, Universal Bond from Bisco, Prime and Bond. Those are all ethanol-based adhesives. The point is here that they said blowing time had no influence on the bond strength. If you read this super fast, you might conclude that air drying time is irrelevant or inconsequential. So you have to know which solvent you're using to draw these conclusions. On the other hand, extension of air blowing time tends to have a beneficial effect on the ethanol-based adhesives. Scotch Bond Universal, All Bond Universal from Bisco, so on and so forth. Another article here. This is from the Journal of General Dentistry. Prolonged air drying resulted in significantly greater degree of evaporation than did the time suggested by the manufacturers. Why do we think that the manufacturers put less time? A few of you guys have been on when I try to show the Something About Mary video where they're driving in the car and he comes up with the brilliant idea of 7-minute abs versus 8-minute abs. That's a very important concept to understand, that in the world of advertising and selling products, whether it's associated with medicine or not, there's a race to the bottom. Manufacturers know this. They're not putting what is going to produce optimal results. They're going to put in there which produces the best results compared to their peers that has a comparable set of directions. So you could imagine the best bonding agent in the world has 57 steps. You going to use it? Probably not. There's a reason why we don't use products like Panavia anymore or C&B Metabond. Very good products for what they intended to do, but they were super technique sensitive and had many, many, many steps. The point is that dentists are always looking for simplification and decrease in time involved. There's a compromise on the other end of that. So do know, and this was a really good article, and I love what they put here, and I highlighted it, that what they concluded was that the manufacturer's recommendations were inferior. So earlier in the lecture, we talked about the fact that most dentists don't even meet manufacturer's needs. And then we have an article here that says manufacturer's requirements are actually inferior to what is actually optimal. The point is, the amount of time you spend in a day on these processes is really not that significant. But dentists focus on how long it takes to scrub their dentin adhesive when they take 25 minutes doing their cavity prep with a 330 burr. It's like, focus your effort and energy in the things that actually make a difference and have very little, if any, clinical outcome, and optimize and do the things that really do matter, that actually do benefit the clinical outcome in the long term. This was a really good article. So I'm transitioning a little bit to the topic of universal adhesives. I'm a big fan of universal adhesives, but after doing the lit review this recent time, I found some articles that kind of dissuaded me from maybe thinking that they're super special, and I'll tell you why. Wow, it's 8:12. Everybody still here? Everybody gone to bed? All right, I will
Everyone
not.
except for Ryan.
What's that?
You're just
Everyone's here except for Ryan.
All right. I'm going to keep going, but if you guys want to bow out, I will send you the recording. But I'm going to talk a little bit about universal adhesives and MDP. So if that will interest you, I promise you there's fruit on the other side of this tree.
Keep going, man.
All right.
Bring us the.
All right. So bonding of universal adhesives. What are universal adhesives? Let's see. I'm a little lost in my lecture here. Let me just articulate this. Universal adhesives are essentially 5th generation in technique. In other words, there's an etch. Let me back up. Universal adhesives were intended to simplify the topic of generations of bonding systems. What they came up with is a adhesive that can be used in any way. You can etch, rinse, and then apply and cure. Or you can selective etch, just etching the enamel, dry, cure, rinse, dry, cure. Or you can use it as a self-etching. Now, obviously, the bond strengths of those different modes differ. We're going to go over what the optimal way of using these might be. But the literature actually articulated the fact that we're actually a little bit misled on how amazing this system is. And the title of this article, and again, Pashley and Tay, these are two guys that have been, these are PhDs that study dentin adhesive for a living. They were co-authors of this. And the title of the lecture is Bonding of Universal Adhesive to Dentin, Old Wine in New Bottles. Let's take a look at what that means. There you go, Ryan. More drying is better. This was a slide that should have gone up. The point is you can't over dry your resin after you apply it. That slide's out of place. Wow. Yeah, I'm a little bit out of sequence here. Give me a second. So this slide I had put in here to articulate the fact that when we're drying the resin, we really want to dry it well. What do you think would evaporate first? A pond, a lake, a sea, or an ocean? It's pretty obvious. The less volume there is, the more evaporation will occur as a function of the total surface or volume of the body of water. We really have to dry well in order to get deep into the hybrid layer. So that was the point of this. I wanted to stimulate it. And then here was a series of slides where I talked about this. Here I have the suction from the assistant. This is on. Here we have the air water syringe tip. And in essence, what we're doing by drying is we're allowing more resin to be present and less solvent to be present in the hybrid layer. All right, so the more we dry, the better that interaction. More resin, less solvent. So the evaporation of the solvent is the goal during this part of the process. Well, how do we increase evaporation of the solvent? We increase the time. I showed you an article several slides before that said 15 to 30 seconds. That's an eternity, but the point is that the longer we do it, the more we're going to drive off the solvent, the better the remnant hybrid layer. We can also encourage evaporation through positive pressure, through the use of an air water syringe, negative pressure through the use of suction. Follow the directions, it's always part of the equation, and then again, time. When we're done, this is what our hybrid layer should look like. We've properly infiltrated the dentinal tubules. We have a properly demineralized zone of the intertubular dentin with resin infiltration pretty deep. If we do all the steps well, this is a properly hybridized hybrid layer and one that is going to stand the test of time, or at least give us the best chance long term. And again, I do these 2 steps twice. So bonding application, scrub for 20 seconds, air dry for 15 to 30. I probably do 15. It's probably actually 10, but if I say 15, it's probably going to be longer than 5. I think you get my point. And then I do the same steps again. Again, no light curing between the 2 steps here. That's been shown to actually not be effective. Again, that's our hybrid layer. And then last, we light cure. Why do we use this light? This is the strongest dental curing light known to man. The Velo produced by Ultradent is another good light, but it produces about half of the intensity of this curing light. Why is it that there's a light that has double the power to the next best curing light on the market? There's a concept out there that is the following. If you cure too fast, you stress the polymerization process and you decrease the integrity of the composite and the bonding layer. So this concept is true not only for the adhesive layer, but also the composite. Somebody very smart at a Yankee conference several years ago said something and it stuck with me, and I've since corroborated this in the literature, and he said the following. The polymerization process on a nanoscale level is irrelevant. In other words, this might be fast to us, 3-second curing times versus 20-second. That's fast to us, but to a molecule, it doesn't matter. All right, so the speed of polymerization has not been shown. It's been shown, but those supporting arguments, I think, are weak to stress the macro integrity of the bond layers or the restorative material itself. What is the point here? A really good cure is as important as every step we just talked about, which is why we use this light. Plus, it's faster, and it's a really durable light. I think these are, $1,200 a piece. The ladies drop them at least 20 times a day, and they do pretty well. So I love this light. We've been using it for almost 12 years now. This is the second generation of this light, and it's done very well. The other part of this is something called the typodont study, and this is my attempt at articulating this topic. There's a guy from, I think he's Dalhousie, Ed Price or Dr. Price. He's one of the two leading scientists when it comes to dental curing lights, and he did something where he took a typodont and he put it into a fictitious head and mounted it to a dental chair, and he put a light sensor at the bottom of a class 2 prep. Very, very, I think, important and elegant study. And he had dental assistants come in, and they didn't know what they were doing. I think he was just saying, hey, let's practice some light curing of our adhesive layer. And what he found was the accuracy of the light to deep layers like that is extremely, extremely filled with error. So the point is, regardless of the light you use, one of the most important steps to the entire bonding process is making sure your assistant, if your assistant's the one that's putting the light on, isn't telling you about their weekend and looking you at the face and they're 3 millimeters off from the class 2 prep. This is the most important step in the whole process. If you don't get this right, it doesn't matter whether you use Gluma, use chlorhexidine, 3 layers, 2 layers, 1 layer. This is it. Make sure that light is getting down deep. And if you're unsure, do it yourself. The typodont study showed that the average dental assistant and even the clinicians are not able to cure class 2 composites well down deep. Super important. So here's the summary slide. If we did everything right, we have our resin tag, which goes down into the dentinal tubule. We have our hybrid layer, which was once mineral, was demineralized and replaced with resin, interspersed with collagen. Here we have exposed collagen network. We don't really want that. This slide is just trying to make the point that if you don't drive the solvent deep enough, you're going to have exposed collagen here. Not sure if that really contributes to poor clinical outcomes or not. What I'm advocating for is sufficient time with scrubbing of the adhesive layer to get it down deep so that we have no exposed collagen. And then we have the undemineralized dentin. In other words, where the etch didn't reach. Altogether, this is the interface that we deal with every day. Very easy to screw up. The modern materials have definitely tilted the scales in our favor. But understanding this process, I think, will add some credence into this process here.
Quick random question.
Yes, love random questions.
How many, in like a standard 30 MO, how many tubules are we working with here? Is it like hundreds? Is it thousands? Is it?
Good question. It's definitely hundreds and thousands, not tens.
Yeah.
Yeah. I mean, if you look at an SEM, you're looking at, like a 1 micron slice, you might see 10 of them in there. So you kind of multiply that to a millimeter. Yeah, it's in the thousands. Yep.
Thanks.
You're right. That was random, but love it. Here we have the directions for Scotch Bond Universal and All Bond. And I put this in here because I wanted to highlight this. All Bond Universal, apply 2 separate coats. We have both of these in the practice. How many people have seen this? We use the same process with all of the materials. I know this happens, but in reality, this application and this header here is actually incorrect. So I'm just going to go ahead and delete that. But here it says apply 2 separate coats of the adhesive with agitation for 10 to 15 seconds. There, again, agitation. So there's our NECADE bonding protocol. That's what I wanted to do. This is something I've wanted to do for many years. I've constantly been modifying how I do my bonding process. This is where I currently stand. I have no doubt somebody's going to challenge me with an email after this and maybe move my needle in a certain direction. But what I can say is this is far more scientifically sound than just winging it, which is how most people, maybe not everybody here, maybe nobody here, but many people in the profession just wing it. They just take whatever the assistant gives them, they scrub for however many seconds they think is right, they cure it, maybe they get it, maybe they don't. Done well, this is a predictable process. It's also a process that decreases sensitivity. So I promised MDP. All right. Again, you can bow out anytime. I got about 10 minutes left. What is MDP? Well, this is the biphasic molecule or the monomer that we talk about in our adhesive resins. So here we have our methacrylate end. Here we have a hydrophilic phosphate end. And then we have the carbon backbone. The length of this carbon backbone gives it its I wouldn't say its hydrophilicity, but its biphasic nature. We talked about HEMA earlier. HEMA is 1 carbon with 2 hydrogens, and this and this. So it's a 1 carbon backbone version of MDP. This is a 10 carbon backbone. This has been shown to produce more of an ionic bond to calcium. That's why this is so special. Like, what is it about MDP? Everybody talks about MDP. MDP was first introduced into bonding resins in 1980 by Curare in their 6th generation Clearfill SE product. So we've been talking about this Clearfill SE product. What's so special about it? Everybody thinks it's because of this. Again, they had a patent on it for 22 years, ran out. Other companies started adding it to their products. Here we are with universal bonding. So this is the difference between 5th generation bonding agents and universal adhesives. MDP is what gives us the ability to quote unquote bond to metals, to bond to zirconia. I think we've all seen the advertisements that universal adhesives bonds to everything, including peanut butter and jelly. It's somewhat true, but those bond strengths aren't necessarily equal across the board. The point is, there's something special about this, and what is special about it is the following. Here we have our composite, we have our hydrocarbon chain. Our phosphate end, when the hydrocarbon chain is long enough, has an ionic potential to actually bind to the calcium of apatite or hydroxyapatite. We talked earlier about the fact that everything in Dentin bonding is a micromechanical interaction. And then in the beginning I said, well, maybe there's a chemical interaction. This is it. This has not been substantiated to translate to clinical outcomes, which is why that article earlier said old wine in new bottles. There's a lot of studies that need to come out on this, but what I'll say is this is why we use Scotch Bond and Universal Bond from Bisco. Because in theory, an ionic interaction between the phosphate group and the calcium in the mineral component of the hybrid layer, in theory, would be more stable long term. That's the theory. This has not been proven. I thought it was when I saw a Spear lecture that said, MDP is the most amazing thing, and then, so on and so forth. Everybody was excited. The literature hasn't substantiated this. So here I am, here I am in 2015. I had all of these slides, and I'm like, MDP is the best. Fast forward to my lit review now, and there's quite a bit of literature to say this is probably not as significant as we once thought. So several articles debunking the benefit of MDP. With that said, it might work, and it has no downside to it. The fact that it has a very long hydrocarbon backbone actually does have other benefits to it. Also, Clearfill SE, for whatever reason, which is a self-etching adhesive, has really stood the test of time. So when you look at the adhesive literature, you're going to see the gold standards, OptiBond FL, and Clearfill SE. Very different products, very different protocols, but the point is there was something special about it, and I do believe this is it. Just hasn't translated into literature that supports why, and it hasn't been translated to actual better clinical outcomes. So for the moment, we're using universal adhesives. I wouldn't be surprised if in 5 years from now the literature changes. But I do believe that this particular class of adhesives to be the most forgiving, universal adhesive that we have in dentistry today that works in most people's hands. If you are super astute and you want the best bonding protocol, Van Meerbeek studied that back in 2007. I'll gladly send you the article. It's not for the faint of heart. There's many steps involved. It's much more technique sensitive, but it's very good in its bonding longevity over time. So on that note, we went past an extra half hour. What are everybody's thoughts here? Was this all super obvious? Some of it new, all of it new?
Okay, boss, we'll bond better.
All right.
I did have to use Panavia today.
You know, when I said Panavia, I was like, I know Steve is familiar with it. You know, I mean, those classic, older is sometimes better. And I think in the world of dentin adhesion, those products are amazing. But would you agree they're more technique sensitive?
Oh, yeah.
Yeah.
I'll only use it as a last resort.
Yeah. You know, but it's still used a lot, just not something that's taught in dental school anymore because of its technique sensitivity. Anyone else? Thoughts?
I'll definitely start scrubbing my etch now.
Honestly, just scrub more. Scrub your etch more, scrub your bond more. You know.
You mentioned what happens if I know you dry, but can you just briefly touch on the hydrophilic nature of bond versus etch? Because I was recently taught by a lecturer who stated he never air dries because he doesn't re-wet with chlorhexidine, and he has a million reasons why he doesn't do that. But he was so specific about not drying, and then he would come in, he does a single layer of bond, but he had like some really specific hydrophobic tendencies relating to the bond, which made that acceptable. And I'm still kind of stuck on that.
Yeah. Let me.
I think some of the agents were designed so that the alcohol or the acetone would come in and displace the water instead. So
Correct.
Theoretically, you would not have to dry, as opposed to slightly over drying and then re-wetting and then putting your bonding agent, which is going to soak in and replace the water. I don't know.
Yeah, no, I mean, Steve, you're right. The current ethanol-based adhesives are intended to be wet, because ethanol chases water out. Ethanol will displace water. It has more, physical properties that displace it. Zach, I think the answer to your question is that whoever this was probably was not over drying, so he didn't need to re-wet. I don't think that's bad at all. You know, at the end of the day, he's leaving a properly moist surface. He probably has read the literature that I just shared that chlorhexidine doesn't have any long-standing effect that's translated into clinical performance. So I was very transparent about that fact. With that said, I would rather have it in my mouth. I mean, at the end of the day, 2% chlorhexidine is 98% water. So tomatoes at that point. I just like the fact that it's antibacterial. If there's any bacteria trapped in that hybrid layer, that 2% chlorhexidine is going to kill that. Does that translate to pulpal health? I think it might. You know, at the end of the day, you trap an anaerobe somewhere in that hybrid layer. Could that anaerobe make its way to the pulp tissue and cause irreversible? Absolutely. Has that been even theorized? No. That's just what goes through my head at 11 at night when I can't fall asleep. I can't say whether that matters or not, but 2% chlorhexidine versus 100% water, it's the same thing. But I think what you just articulated was the fact that he didn't over dry it. He just optimized the wetting by doing the following. Here I had a slide about optimal drying.
What I was really interested in, because I had been doing our protocol, and so I always dry, and I was like, well, what happens if you leave etch in there even after you've rinsed and you can't get it out even if you spray it? And he was like, I'd put Bond on it.
Oh my God, that's horrible.
I mean, I almost fell out of my chair, but he followed it up with like a very rationalized explanation of why it made more sense. And I still think about that actually sometimes when I'm doing a filling.
Yeah. I mean, that's been studied. Leaving etch residue 100% interacts with polymerization. That was studied a long time ago. I think what he was saying is that he just optimally dries it rather than over dries it and then re-wets it. What I put here is I actually intentionally over dry it so that I can re-wet it with chlorhexidine. At the end of the day, it's far more important to have an optimally wet surface than any of these conversations. So how do you create an optimally wet or optimally dry surface? When I was in Honduras, there was a Honduran dentist that worked in the room next to me, and she used cotton pellets. And I know that's probably a well-known topic, but or a well-known technique, but at the time I had no idea. I had never heard of that before. So using a cotton pellet so that you get not pooling of moisture, but optimal sheen on top of the surface. So there's a right amount. And, look at, just go on Google, type Google Images, optimal dentin wetness, and see what comes up. There is an optimal amount, whether you get there from drying just so, or you over dry and then re-wet. So I'm not sure if that answered your question. I think he was speaking the same language, just getting there from a different path. Cool. Well, very well. This is the longest NECADE session we've had. And wow, we still have some people left. So thank you guys for hanging out. Please ask questions. This is one of my favorite topics in dentistry to talk about. I promise you that some of this might change in the future, but this is a scientifically sound protocol. See what you can do, and hopefully it'll improve your process. If you learned nothing tonight, just read the directions from your manufacturer and get a timer out and actually follow the time. That's probably the most important part of this.
Sounds good.
All righty.
Thank you.
Everybody have a good night.
I guess.
Thank you.
Get the shovels ready.